That's right. That's right. Oh, pain.
3 more days.
That's true. Is it already that time? Oh, do you guys just do pain rounding to start you up, or?
No, I do. I start regional on Monday.
On Monday. Okay.
I haven't gone to the OR yet, but one day. Yeah.
All right.
I'm Blake.
Blake, nice to
nice to
meet
meet
you. All right. And where do you get? Where's everybody from?
I'm from here. We're married. We're couples match.
Oh, okay.
I'm from here, so that's why we.
Okay.
I'm from Sacramento.
Okay. All right. You didn't pull her back to California. I feel like everybody makes their way back to California. So,
Oh no.
Just like
That was kind of understood fairly early on.
Okay.
I gave her that tug of war.
But now we know who wears the pants. Right?
It was never a question.
Yeah.
No shit.
Yeah.
All right. Okay, Blake from Sacramento.
I'm Eric. I'm from Grand Rapids, Michigan.
I'm Dan. I'm also from Sacramento area.
All right.
What?
And I did med school out here.
Okay.
Yeah.
Great. Nice to meet you.
I'm Carly. I'm from St. Louis. I'm Isel. I grew up in Ecuador.
All right. How did you end up here?
I did undergrad in Indiana. I got a scholarship, so I ended up here.
Oh. We're in Indiana.
Purdue.
Where?
At Purdue. Yeah, I'm in med school. How are you?
I'm Ian. I'm an intern and from Minnesota.
Nice to meet you, Ian. Welcome. So did any, a couple of you are in scrubs and I've seen you around the OR. So anything of note today that we could kind of pick apart as a kind of rapid QI something? If you didn't have anything, that's fine too. I can think of something.
I had something yesterday.
Oh yeah.
Cheers. I hung a phenylephrine bag on the IV pole, but I didn't connect it to anything.
Uh-huh.
And then my attending thought it was the ANSEP and plugged it in. And so just a little bit of phenylephrine bolus.
Oh.
We identified it pretty quickly
Uh-huh.
and just turned up the gas and gave her much
No. Okay.
But yeah,
So that's like a medication error, right? So if it's actually kind of a pertinent discussion because I don't know, those of you who will start in the OR will notice that we have a lot of look-alike medications. Not only like in bag form where it just looks like a 250 bag with a label printed on it, but also in our medication drawer as well. Hey, you're welcome. In our medication, like our second drawer, like for a while there we had, I think it was phenylephrine, like 10 milligram per mil vials that were right next to the Zofran. Both of them were little 2 mil vials. Both of them had blue caps, and they were sitting right next to each other. And you can imagine pushing 10 milligrams of phenylephrine would be a big bad problem. And so, there has been medication errors just because of look-alike, sound-alike medications, like in our drawers, where we as anesthesia practitioners are so used to just grabbing things and giving them ourselves. It's a very unique problem to our department because everywhere else there's a nurse has to have the order, that order has to be verified, then they can pull it out of a Pyxis, and then, if it's a scary medication, then it has to also be witnessed by someone else if they're removing the same drug, and it only gives you access to that one little drawer in the Pyxis, so you can't accidentally pick anything else up. Meanwhile, here we are, we're super cowboy about everything, and we're just like, I'm just gonna push that, I don't want to wait for anything. I don't want to do a check on anything, and that's a good example of that, right? And so, okay, So if we think about like when we're, so who are the stakeholders when it comes to medication error like that? So who is it that can offer us some input as to, who this would affect? Obviously us, right? Anesthesia. Who else would be involved in that process? The patient, right? Who else from a systems standpoint, with regards to the hospital could be involved in a process of helping to reduce medication errors? Pharmacy, right? Pharmacy would be a big one. Anesthesia would be the big one. And then also we need to say, okay, well, who did this affect? It affected the patient. What was the scope and severity of that effect? In this case, not much. It sounds like it's like maybe temporary, reversible harm. Who knows? But if that happens to the wrong patient and they have a heart attack, they have a stroke, they have some sort of embolic event because of severe hypertension that's uncontrolled, then this becomes a bigger deal. So this is the whole this is the whole point of the QI process, right? We had a near miss event, and so how can we look at that to say this isn't going to happen to the wrong person or to any person, right? How are we going to fix that problem? So, when does it happen?
When you're like pushed for time and you're reaching for them.
Mm-hmm.
Like they're gonna do the timeout, so you get the antibiotics in.
Mm-hmm. Yeah. And this, you can also be very literal about it. So it's when they ask these questions, it can be literal, it can be figurative. So it happened in the OR. It was a bagged drug that is in the top drawer of our cart. Why did it happen? Human error, right? Like he's trying to get the antibiotics in. I'm gonna hook it up. I'm not gonna double check with anybody who actually set up the room. It's just someone that's fluttering in there, trying to get everything done, and then they're gonna leave again, right? But they're not the one that wet down the drip or set up the drip. And so there is a big human component to this as well. But sometimes that human component is influenced by the kind of processes. We're all creatures of habit, right? Like I was saying, we're used to just grabbing something out of the drawer, slinging it into the patient. Similarly, when we create situations like this, where there's multiple medications that might look alike, we get used to assuming that one thing is one thing and this thing is the other thing, and we don't check a label every time we put something up, right? And so there's could be something from a process improvement standpoint that we could try and change that culture as far as everyone's habits, right? So, obviously we're just breezing through this. Obviously you keep time on each of these steps here. But, so the next step would be a process map. And so in this situation, what we would do is kind of think through, okay, pharmacy is mixing these drugs for us. They are pre-diluting these phenylephrine drips into these bags. They print a label. And then it miraculously shows up in the top of our cart, so we're not having to call them and ask them for it all the time, right? So they mix it up, they print a label, it looks like every other label, it gets slapped on there, it sits in a refrigerator somewhere. At some point in time during the day, the pharmacy techs come through and refill our carts and see what's missing, replace whatever. That's also somewhere where a medication error could occur, right? Are they putting it in the wrong spot? Did they refill the top drawer with the wrong bag or something? Maybe it was a bag of Norepi and not phenylephrine or whatever. So, this is where you can pick apart every little step of that process of how did that bag end up on that, hooked up to that patient, right? And so you make this process map, and every little step of the way you can pick apart what are the contributing factors to where error can occur. And a lot of things do come down to human error, and we are human, and we are going to make mistakes every once in a while, but it's like, how can we implement systems to keep this from happening? So then from that process map of like, how did this occur, we can try and get down to a root cause analysis. And so in that, I wonder if I can pull up that fishbone diagram up here just so we can look at all the different kind of components of that fishbone and see if we can think of uh-oh. It doesn't trust me, which is probably a good thing. But so like when we're thinking about that fishbone, so one of the big kind of bones of that fishbone is human factors, right? And that's, I think, where most of, if we were doing a fishbone analysis of this event, that's where we would kind of see most of our entries falling into. But that doesn't mean we don't need to think about the other ones. So like a medical knowledge. Was there any sort of medical knowledge component that went into this error? I don't think so, right? So it's like there wasn't a competency issue on the part of you or the attending. There wasn't a lack of orientation to the process of, spiking the med and delivering it to a patient, right? So medical knowledge, we can kind of leave that little bone of the fishbone pretty rare at that point, right? Patient factors, is there a patient factor involved in this type of error?
So she was obese and was getting 3 grams of ANSEP
Mm-hmm.
instead of the normal 2 grams, which is why the ANSEP also came in a bag.
Mm-hmm.
It's like a little syringe that it normally comes
So it wasn't the usual, it didn't look the same as it usually does, and it probably had the same black and white sticker like the phenylephrine bag did, right? So that's a big portion of probably what happened here, and so we can write that down as a patient factor. Was it a compliance issue on the patient side? No. Was it did it have to do with a language barrier or something along those lines? No. And so you just kind of go through and pick through what could be a contributing factor. Was there any sort of clinical issue involved? Probably yes for this patient. If you had high enough suspicion that you needed a phenylephrine drip, that it was spiked and hung, before the case even started, then there probably was some sort of clinical assessment that led you to believe, okay, I need to have this hung. I also need to give this 3 grams of ANSEP. You can kind of a low impact, thing to consider, but basically we're trying to gather all the information here. So therapeutic choices. So contributing factors may include fatigue. Could have been a fatigue issue on that part of the attending, and that they're coming in, they've got a million things to do. Multitasking is another big problem with human error and anesthesia, because we are always multitasking, right? There's never a time when we're just doing one thing. Took a shortcut, the attending took a shortcut, right? They didn't read the labels before looking at that infusion into the patient, right? Improvising, was anybody improvising? No. But, all these are therapeutic choices that people make when they're pressed for time. Let's see. Documentation issues. This was not like a EMR issue, but it is kind of a documentation issue in the sense that all the pharmacy labels look the same, despite one being a vasopressor, one being an antibiotic. Just like we label our medications with color coding, so we can kind of at least group things into classes of drugs. All of our opioids have blue labels. All of our vasopressors have that, striped purple or red, depending on the brand of stickers you use. But is it that much of a stress to say, why can't pharmacy do that as well? So it's an easy visual representation of this is a vasopressor, this is an antibiotic, right? And so it's a little bit of that extra prompt to say, oh, I'm going to read that label before I start wide open on this bag of something, right? So I think that documentation fishbone or arm of that fishbone is something that might be, remember we were talking about high impact but low effort. That's kind of one of those things where it's like, well, I think it would be easy enough to color code a label. How much that would cost, I don't know, and that's what comes into this factor as well. It's like, well, does that mean they have to change all of their printing devices for every pharmacy in the hospital? And in a hospital this big, that might be a big undertaking, right? And so that's when you kind of loop back around and say, well, what is something that's higher impact but lower cost or lower effort that would make a bigger effect on the system here? So is it an equipment or device issue? Probably not. A communication factor. I think that's also big in this, right? The lack of communication attending to you or vice versa as far as what they're starting, what they're opening. Granted, you have to accept quickly. But, if there's ever multiple providers, closed loop communication is so important. Like in a code situation, it's a big factor, right? Communication. Closed loop communication. You're not just going to bark something out. You're going to make sure you say that you heard it, and you're going to repeat that back to me. Role confusion is something that is also big in anesthesia, right? We have this kind of supervisory model and this hierarchy as far as within the teaching structure. Sometimes it's hard to figure out who has what role, right? Well, I assumed that the attending already did the airway exam, so I'm not going to do the airway exam. I'm just going to roll into the room or whatever. Or, I thought you already gave the antibiotic when it comes to somebody coming in for a lunch break or something. I thought you already gave it. No, it's still hanging there and it didn't get, antibiotics didn't get in before the turn came up. It's a big, surgeon's yelling. And so communication can be a huge factor when it comes to these human error issues as well. So then, just to keep things moving forward, like when you kind of pick apart all these contributing issues, that's when you can kind of decide what is it that we can change, how can we measure that change, how can we put that into effect, and then, so in this case, I think my suggestion would be that label change, right? And obviously, communication is always a good thing too. Always a good thing. There's never too good communication. But something like this, so we have monthly meetings where we go through and pick through charts that have been flagged for an issue. For example, I just was chatting with one of our quality nurses. I had an event the other day, an AOP, so it was an outpatient procedure, pretty low risk procedure. The patient was having a hysteroscopy for abnormal uterine bleeding. And she had been intermittently bleeding for like a year or two. And, you know, no other comorbid factors for that patient. From our standpoint, from a pre-anesthetic evaluation or pre-anesthetic testing, you know, what do you think would be indicated for, you know, as far as what would make us feel like they're ready to go as far as receiving a general anesthetic that day? Do you think they need any lab work or studies or anything like that? No, I wouldn't say so. That patient did come in saying she was feeling pretty fatigued. She had had a CBC like 2 months prior, where she was a little bit anemic, but it wasn't wildly off of her norm. Her HH was like 10 and 30. And so, from my standpoint, I was like, probably good to go. The surgeons, on the other hand, you'll find this with the gyne surgeons, they will order at least a CBC and type of screen for every single one of their patients. Right? This is just what they do. It's fine. But from my standpoint, I didn't feel too concerned about waiting for those labs before I went back. She had had prior type of screens in the chart, 2 of them over the past 2 years. Both of them had negative antibody screens. So from my standpoint, I was like, even if the H&H is low, she's looking hemodynamically stable. If she does need blood, it's probably this is more of a chronic process than an acute process. And they're telling me the risk of blood loss in this procedure is pretty low. So I feel comfortable going ahead. She's got a prior negative screen. If you do need blood, it shouldn't take a crazy amount of time to get blood. Murphy's Law, of course, we get her up to sleep. She's doing fine. CBC comes back and her age is like 6. So she's still hemodynamically stable. It's not like urgent that I need this blood right now, but we do want to transfuse her again before we send her home, right? And so we get the type and screen back. It still says, you know, whatever, negative antibody screen in the chart. And we're calling the blood bank like, hey, when's that blood going to be ready? Oh, it's not going to be ready for like 4 hours. She's got antibodies and it's going to take us a while to cross-match this blood. It's like, because it says a negative screen here in the chart. And they're like, oh, yeah, no, she's got a positive screen from like 2002. And so we're obligated, since she had these prior high titers, even though they're not high enough to cause a positive screen, per se, at this point, at some time we knew she had these antibodies, so we have to do our due diligence to make sure that we have something that's compatible even for those antibodies back in, right?
What's the point of the current type of screen?
Exactly, right? So, you know, thinking forward again, minimal harm to this patient. Just took a while to get the blood. She was still hemodynamically stable. She just had PACU for an hour or 2 until the blood showed up, slowly trickled in the unit, and then she was on her way. But thinking to a different scenario where everything, as far as what I can see in the chart, says it shouldn't be hard to get blood at all for this patient. And we count on that, right? We count on that all the time in the operating room. And so, from my standpoint, we've had this issue before, and what we've done with the blood bank is supposed to put in a red blood cell antibody allergy flag, so it like shows up as an allergy, it's pretty yellow, and they'll put in this little verbiage about like this patient has a prior antibody, there could be a delay in cross match for up to 4 hours. This patient did not have that though, and I know we put that in place because I've been heard of prior QIs where we had the blood bank start doing this, and so, you know, the questions that I was asking is, well, is the blood bank doing this retroactively for other patients? You know, we we only see so many, since we've had Epic and the EMR, we only see that many years of, prior results in our results review tab. We can't see prior lab work that's done before the EMR came into effect. The blood bank also has access to other labs from other institutions that we don't have access to. And so, from a provider standpoint, in prepping someone for surgery, because the other thing the blood bank was asking me was, why didn't you get a 30-day type in screening pre-op if you knew that they were coming for surgery? Like, why didn't you get this beforehand? And from our standpoint, it's like, well, we didn't think they needed any labs at all, but the surgical team ordered it. So, if we're going to count on the surgical team to be screening this, like, how will they know that this patient has a delayed transfusion need? How will we know they have a delayed cross-match, time? And how can we prevent this from happening in the future? And so, I think high impact, low effort ways of kind of fixing that is one, making sure that they're retroactively putting in these allergies, and two, educating the surgical teams, because not everyone goes through pre-op clinic. No one, not everyone gets screened by us where we can say, oh, well, we can send this stuff ahead of time. A lot of times we're depending on the surgeons to do this, so how will they be able to know? Do they understand the perioperative management consequences of someone having a positive antibody screen? And, can they be prompted in some way, whether it's a pop-up within Epic to say, hey, will this patient need blood? Like when they schedule their surgical, request order, if there's something that pops up and says, this patient has a prior antibody, do you need blood? And if so, please, get links to the order for a 30-day type of screen. Those are pretty easy things to put into place, but could have a big impact, right?
So I don't know if you knew. So you sound like the step 3.
Mm-hmm.
Take the standardized the computer quizzes.
Mm-hmm.
The correct answer is still for every surgical case to order coags and screen.
Really?
Yeah. So maybe that needs to get changed too.
Maybe that needs to get changed.
If you're like a surgeon and never had a pre-op clinic, you remember for your step 3. You're supposed to do that.
Yeah. That's true. And that's like the, that's that one arm of the fishbone analysis, medical knowledge, right? And where's the knowledge gap? Some of the old school surgeons will still rainbow labs for everybody that's coming to the OR, no matter what their comorbidities or what, intermediate or high risk surgery that they're having. Order the same thing for everybody. So it's a big strain on the system, but it's much easier from their standpoint to say, well, you're not going to cancel because I forgot to get this one thing because I already had it done, and so it's like, and everybody's strapped for time. People take shortcuts. So, yeah. So you'll come across this stuff all the time. My little plug is please put in a RL when you do, even if it's the little stuff. Because when little stuff happens a lot, it's something that we need to address. It doesn't always have to be this person coded because of X, Y, and Z. And it's oftentimes a lot of just little day-to-day things that happen over and over again because there's a systems issue, So that's my little plug. Does anybody have any questions about? I know this is kind of a softball topic, but any questions about it? You guys interested in it? No.
No, we're at the VA.
At the VA.
Yeah.
Oh man, so you guys have to drive. Or not. It's a new VA now. I'm still back in Colorado.
Yeah, we were
Drive.
It's raining. He's still driving.
Yeah, still
It's far enough. It's raining.
tried
Alright.
walking the first week. I got tired.
It's longer than driving, so.
Yeah.
And they usually
You have
get
to
lost
walk
on the
back.
little late anyway.
Yeah.
Oh no. Goodness. You have to go back after?
I make sure they do it pre-ops.
I haven't been to one Same location, but
Function is the same.
Function's the same, but it's
Yeah.
just the same old. Yeah.
People that paint, yeah.
People are awesome. Same old system.
I didn't get your name.
I'm Stephanie.
Caesar. And then Zelda's.
Oh,
It's good that my case then.
I'm Suki. I'm one of the general attendings over here. And I'm the friend as well. Maybe by the time that you guys are finishing up, you'll be out there.
Is that what they're trying
I think it would be a good location, just like we have kind of that senior month now where you get a little bit more, like supervision, practice, and like kind of running the board, running the facility, that kind of thing. And so Broomfield would be the perfect place to have you guys do that as well, because it's 3 hours, it's small, it's manageable, and you could just be like kind of the sole provider out there, you know, and then you'll get really good experience with autonomy and supervision and kind of
That's awesome.
running the show. And so hopefully, I don't know, they have to change some designations on that hospital as far as like allowing trainees and things like that, but that's what I'm hoping for you guys, just like Lone Tree, AOP, they'll let you guys do that a little bit. But and it's just a different hospital setting, right? It's nothing like here. It's not a surgery center like Lone Tree, and so getting that like small community hospital feel, I think, is also nice for you guys to try out all the different types of locations before you're like looking for jobs and such. But that's like one of the big benefits of being at this program is that it sucks to have to like move around between hospitals all the time, but you do get exposure to so many different types of practice and different anesthetic cultures as well, right? Like I'm sure you'll notice when you hop from one hospital to the other, everybody's kind of got their own things that they like to do, and this is the norm here versus this is the norm here. Also from the surgical side too, we don't have do the same hand surgery here versus over there, and one person will want a ear block, one person will want, oh no, I'll just do a local with neck, and another person will want, you know, full peripheral block, and it's just getting to see that variety, even though it's a little frustrating when you're starting out, it's pretty awesome when you get out into it. Good job. Yeah. Alright guys, well that's all I got for you.
Thanks.
Yeah.
Thank you. How's your first year going?
Really?
Yeah, we got one.
Last year we got C.
My first game was like second shirt.
Yeah, no, you guys come is so nice.
You guys in our game.
Yeah, he is another. Fellows and
Caesar.
another.
So I met David then too.
David Mack.
I think yeah, pretty watery.
Yes, which is actually awesome. Yeah.
Yeah.